Today we're going to talk about Chapter 6 in our Dale Dubin book, and that's going to cover blocks, AV blocks and bundle branch blocks. So we're going to start with AV blocks right now. So one of the main things that we need to understand is what's actually happening when we're going down through the AV node. So within the AV node, right, that's kind of, think about our doorway that leads the atrial signal down into the ventricles to produce that ventricular contraction, right? So I like to use that analogy, right? So we have the sinus node that fires, that signal propagates down through the atrium, right? It reaches that AV node to allow blood to move from the atrium down to the ventricles, okay? And then the ventricular system is the bundle of His, splits that signal into two down into the bundle branches, and then to the Purkinje fibers, and we get depolarization of the ventricles, okay? So with AV blocks, what we have is we have a little bit of issue here at that AV node. So remember that AV node is there to kind of allow time for blood to move from the atrium down to the ventricles during atrial systole and ventricular systole, right? Depolarization, okay? So in a first degree AV block right up here, what we see is we have a progressively long, a prolonged PR interval, right? Greater than 0.2 seconds. So to refresh our memories, our PR interval should last between 0.16 to 0.2 seconds. Now this is going to happen where we're having this prolonged PR interval, and it's going to be consistent with every single beat that you come across. So if you measure that PR interval between these two beats, they should be identical. So that's going to be the first way to identify, right, if you have a first degree AV block. And you have to remember that we're getting these through the sinus node. So the sinus node is firing. The sinus node is firing, and you are just having that little bit of a delay at the AV node. So again, let's recap what you're going to see with every single heartbeat, every single EKG. If you have a first degree AV block, you're going to have a sinus rhythm, whether it's normal sinus, sinus pretty, sinus tachy. And what you're going to do is you're going to investigate that PR interval to ensure that it's within the normal range. And if it's not within normal range, right, then it's going to be greater. And if it's consistently greater with every single beat that you come across, like these two here, right, if it's consistently greater, we're going to deem this a first degree AV block. So you'll call that normal sinus, sinus brady, sinus tachy with a first degree AV block because of that prolonged PR interval. Okay, so let's move on to our second AV block, which is our Winky Block. People call this one, I believe, type 1 AV block. We're just going to go ahead and call it Winky Block because it makes things easier to remember. And then we'll classify our second degree AV block as Mobitz. Okay. So in Winky Block, what happens is our PR interval starts within a normal range, right? 0.12 to 0.2 seconds, right? And then with every single beat that you get, that PR interval gets a little bit bigger. And then the next beat comes, gets a little bit bigger, until finally you're going to end up with a complete conduction block at that AV node. That doorway is now closed. So at first it was wide open, hey, signal from the atrium, come on down through without any issue. Then that doorway closed a little bit, and then it made it a little bit harder for that signal to pass through. It took a little bit more time. Then it closed a little bit more, right? Then that PR interval increased a little bit because it took a little bit more time to get down through the AV node. Until finally that door is closed, that signal from the sinus node fires through the atrium, hits that closed door. Guess what? That conduction does not make its way down through the ventricles, and then I get no QRS complex. But that cycle will repeat, and what will happen again is it will start from the beginning. And the next beat that comes will have a regular or normal PR interval, just like we did at the beginning of the sequence. And then it will continue to follow that pattern. So again, that PR interval will have a normal length. Okay, so now let's differentiate between the two. First degree, we have a consistently large PR interval. Okay, in Winky Block, we have a progressively increasing PR interval until we have a dropped beat, or a what we call a non-conducted P wave. So the P wave is conducted, but anything further than that is non-conducted. Let's move on to our second degree AV block, and we call it Mobitz, M-O-B-I-T-Z. M-O-B-I-T-Z, Mobitz. And in Mobitz, what we're going to see is we're going to have a consistent PR interval also. We'll have a consistent PR interval, meaning it's not going to change like this one, right? But in a first degree AV block, it's consistently large. This one in Mobitz, it's consistent within its normal PR interval. PR interval. Should be not a PP, but a PR interval. Okay. So what you'll see is you're going to see a series of normal looking sinus beats, right down here, normal looking sinus beats, and then what we're going to see is we're going to have a P wave with a non-conducted QRS behind it. And what can happen is we can have that back to back in Mobitz. So in this example here on the board, we have a sinus beat, a non-conducted P wave, followed by another non-conducted P wave, followed by a sinus beat, then another sinus beat, a non-conducted P wave, and a sinus beat. So here we have 3 instances where we had a P wave with no QRS, meaning that doorway that we discussed just a second ago, instead of creeping closed, is slamming shut randomly. Okay, and that can occur in a random fashion, but it can also occur in a pattern. Sometimes what you might see is, hey, I'll follow a pattern where I will have 3 normal sinus beats, and then that 4th beat, I don't have a QRS, right? I'll have a non-conducted P wave, and that's when the door closes. And then that pattern will continue. Then I'll have another 3 normal, and then the door closes, no QRS. 3 normal, then a P wave, door closes, no QRS. Or it can be randomized like this. These are a little bit more dangerous, right? At least if we have a pattern, we know that we're getting full contraction of the ventricles in those consistent pattern type Mobitz AV blocks. Okay, with all of these so far, except for the first degree AV block, with both of the second degree AV blocks, because we're getting these non-conducted P waves down through the QRS, a little bit more attention needs to be brought to them. They'll need to see their doctor, their cardiologist, likely be recommended to see an electrophysiologist, a cardiologist that specializes in the electroconduction system of the heart. They'll do electrical mapping in order to try and correct this, but likely what they'll need to do is probably insert a ventricular pacemaker, one of the types of pacemakers out there. So let's move on to our third AV block, which is our most dangerous one, and we call it a complete AV block, And that's our third degree AV block, And what occurs in our third degree AV block is we'll have a PR interval is inconsistent, but we're also going to see a wide QRS complex. Okay, so our PR interval is going to change. It's not going to follow any of these patterns that we've kind of just discussed. It's going to change within its own rhythm, okay, within its own strip. And then when we think about this, when we have a complete conduction block of the AV node, that means that doorway stays closed. There is no signal that will come from the atrium through that junction. Okay, that junction is closed off, bridge is closed off, can't cross. Okay, so if we think about this, well, if the sinus node is firing and we're depolarizing the atrium, we're going to get a P wave. But because of that issue at the AV node where we have a complete conduction block, right, it's completely blocked off. So that signal that travels from the sinus node never makes it past the AV node. So that down here in the ventricles, we're thinking, hey, what's going on? I have no signal. Something must be wrong with all of those cells up there. I must be in danger, right? So a ventricular cell, one ventricular cell, will escape what we call overdrive suppression, and it will now become the dominant pacemaker because it is not receiving the signal from above. But it's not because the sinus node's not firing, it's because that doorway is closed. So it's coming down, it's blocked. So I'm not receiving anything from down here, right? So one of the cells in the ventricles fires to be the dominant pacemaker because it does not recognize that the sinus node is firing. So ultimately what you see on the EKG strip, you won't see them separated like this, but ultimately what's happening is all these in red here are P waves, right? Because the sinus node is firing, but the signal doesn't travel past that AV node. Well, the ventricles down here, they have no idea that the sinus node's firing. So what's going on is you have an independent contraction or an independent rhythm of the atrium and an independent rhythm of the ventricles. Now, because the atrium or the sinus node has its own inherent rate, 60 to 100 beats per minute, somewhere within that range, around 80, 88 beats per minute, whatever it may be, the ventricles too, those ventricular foci, have that range 20 to 40. So they're going to pace at its range somewhere in the 20 to 40s, and you're going to have that sinus node firing between 60 to 100. And when you smash them together and overlap them, it's going to look like a big mess, right? But what you're going to be able to identify, and how you'll be able to identify it, is that you're going to have an inconsistent PR interval, and you're going to have a wide QRS complex. So maybe your first PR interval that you think you identify might be 6, 7, 8 boxes wide. Well, then the next one might be 4 boxes shorter. That doesn't follow the pattern that we talked about with Winky Block, nor does it follow the pattern for Mobitz, right? So you're going to have to pay close attention to the QRS complex, because when you see the wide QRS complex, you're going to be able to identify. You need to be able to link the fact that, hey, a wide QRS complex means I either have a bundle branch block, I have a premature beat, I have maybe a ventricular tachycardia, but if it's this slow, it's not ventricular tachycardia, or I have a ventricular escape rhythm. And understanding the physiology and how that conduction system really works is we have the sinus node, AV node, bundle of His. Once I'm in that bundle of His, I split into 2 bundle branches and then the Purkinje fibers. But at that split, that means the right and left ventricles depolarize at the same time, means I'm going to have a narrow QRS. Here, in a ventricular escape rhythm, the signal originates from either the right or the left ventricle, and then it'll depolarize that ventricle. Then it's got to go up the bundle branch, down the other bundle branch, and then out the other Purkinje fibers and depolarize the opposite side. Well, that's a much longer time than splitting into 2, depolarizing at the same time. So that's what leads to this wider QRS. So in a third degree AV block, what you're going to have is a combination, an overlap of this atrial rhythm, giving you your P waves, and this ventricular rhythm, okay, giving you your QRSs. And we'll go ahead and we'll do a couple of examples in class.